You're listening to Psych with Mike. For more episodes or to connect with the show with comments, ideas, or to be a guest, go to www.psychwithmike.com. Follow the show on Twitter @PsychWithMike or like the Facebook page @PsychWithMike. Now, here's Psych with Mike.
Welcome into the Psych with Mike Library. This is Dr. Michael Mahan, and I am here again with intern Michael and Brett Newcomb.
Once more, dear friends, into the fray.
That's what I
unleash
into the breach. Into the breach.
Yeah, I know. I hadn't started the quotation yet.
You say that every time I.
Never mind.
Say that once. Okay. And then I say, "Oh yeah, you're a Shakespeare guy," and then you say, "No, I'm not." I'm like, "Oh yeah, you always quote Shakespeare."
I'm a liar.
Okay. All right. So, how's everybody doing today?
Doing well.
You said some incredibly nice things about intern Michael before the mics were hot, and you don't say those things to me, and I'm jealous.
Isn't that interesting?
Isn't that interesting?
Yeah, I wonder why.
Because you don't have.
So are you begging? What do you want?
Anything nice to say? No, yes.
Maybe I just need it. You are so secure in
that's what it is.
yourself that you don't need those compliments.
That's what it is. I don't know. I feel like I got a little post-traumatic stress.
Your wife has asked me to stop blowing smoke in your direction. You inhale too much of it.
Your shirt looks nice today, Michael. Does that help?
Thank you. Thank you. I appreciate that. Uh-huh.
So speaking of PTSD.
Speaking of, this is not your forte, right? Is
not
the
this,
biology.
Not this aspect of
right.
it, yeah.
So you're going to try and hang with it and see.
I'm waiting for clear elucidation from Michael.
Yeah.
Because I know all you'll do is build a clock.
Well, the reason why, for me, the biology is important is because understanding the biology helps me to understand the concept, and I get that isn't everybody's cup of tea, but I've had clients who have said the reason that I come to you is because you understand the biology really well and you are able to explain that, and that's really meaningful. And that's why I have always said, there's different therapists for different people. Not all therapists are going to be for everybody, but a person shouldn't assume that just because they go to one therapist and that wasn't for them, that means that therapy doesn't work.
No, I can conceptualize being able to get some comfort from saying, I'm really sorry about the way that I behaved when I lost my temper and slapped you, but it wasn't really me, it was my amygdala. Mm-hmm. I'm sure that will help her.
That's not exactly what the article talks about.
Oh, it is exactly what the article talks about, Michael.
It doesn't say that you say, I'm sorry that I slapped you.
Oh, no, it doesn't say that. It said you need to understand that your amygdala is out of balance, and that's why you have these reactions when your stress triggers are pulled.
Well, so the idea here that I think is so important for both clients but also for therapists to understand is that instead of thinking about anxiety as a thing, what we really need to start doing I think as a community of helping professionals is to start thinking about the difference between anxieties and fear-based anxieties, because the way in which those things operate in the brain are vastly different.
Okay.
So if I can paraphrase just a little bit.
Yeah.
Understanding of the biology can help drive the therapeutic approach, because fundamentally there are different mechanics underlying what may appear to be the same consequence, but isn't necessarily the same consequence.
Exactly. And I don't hear this being talked about a tremendous amount. This is what I did my dissertation on. And I don't hear this being talked about a tremendous amount in psychology, but I do believe that in the future we are going to see exactly that distinction. Instead of talking about depression and anxiety as two sides of the same coin, I think we have to think about depression as a separate entity, anxiety as a separate separate entity, but within anxiety, the generalized anxiety disorders and the fear-based anxiety disorders. Okay, so in a regular anxiety disorder, so just the kind of run-of-the-mill generalized anxiety disorder, what I say is that those things operate on the concept of cognitive dissonance. So you have two conflicting thoughts that causes distress in the human brain. Trying to resolve that is what creates the energy for anxiety that most people feel. So I want to go to the grocery store, but I have agoraphobia, and I don't want to go to the grocery store. So that conflicting thought is going to cause me a lot of anxiety. Even easier I worked with a lot of adolescent males. That's typically what I do. And when an adolescent male comes in and says, hey, I want to ask this girl out, but he treats it as if it's a Schrodinger experiment where he wants to ask her out, but he's afraid of creating the answer. So he lives in this perpetual world of, I could ask her out, but I could also, then be rejected, and then that's scary, so I don't ask her out. Now I'm living with both of those things potentially available to me. I could ask her out, or I could not ask her out, and that's what I think is generalized anxiety. So that operates on the same kind of top-down brain function where the cortex of your brain operates on the information and then informs your limbic system whether or not there's a reason to become excited, and then if there is a reason to become excited, then your adrenal gland tells, or your pituitary gland tells what gland to distribute the hormones to start an emotional reaction.
That's response.
Yeah, exactly. So that's typically the way the brain works, is top down. In PTSD or in fear-based anxieties, that gets flipped on its head, so that the immediate activation of the brain are the fear-based response areas like the cerebellum, like the medulla oblongata. And then that causes a fight or flight response to be initiated over which the person has no rational control. So an individual who's been in combat and has seen horrible, horrible things and then gets triggered by a car backfiring, the response that gets activated in that person is not a top-down response, it's a bottom-up response. And so in those fear-based anxieties, the way in which the individual is triggered is radically different. And if you don't appreciate that in therapy, then you could be treating that inaccurately, inappropriately, or ineffectively. So that's my conceptualization in a nutshell. So you're following me so far?
I think so.
Okay. Do you agree with that?
Yeah, absolutely.
Okay.
I have any trouble understanding the concept. I have trouble understanding how to apply it in counseling clients, which is my primary frame of reference. I also have some issues in being able to sort out anxiety from depression, because they're often comorbid. And if you, in my experience, if you deal with one of them, if you can alleviate a level of intensity for anxiety, the depression explodes. Then you have to do that. And you need to tell the client this is likely to happen. And when it does, it doesn't mean what we're doing is not working. It doesn't mean that you're unable to change. It means that's part of what's stuffed down inside you and we're going to have to come to grips with.
Yeah.
Then you have taught me a lot over the years about the biology of depression and the issues there in terms of chemical responses and so on. It's just really an incredibly complicated challenge to then say, however much of that I understand, how do I apply what I understand to hearing the client accurately and being helpful to them? And that's where I get lost in this conversation.
So for me, and what I would say is the extent to which an individual therapist understands or wants to understand better the biology of these different disorders is whatever it is. And I'm not saying that everybody has to be a neurobiologist, But what I am saying is that specifically in the venue of anxiety, it is very, very important to identify whether you think the anxiety is just a generalized anxiety disorder or it's fear-based.
I see that, and I see the value or the merit in saying, okay, this is a reflex-driven fear anxiety that you'll see triggered in this way when a car backfires or when a door slams, a loud noise goes off. So if we know that you're susceptible to that, can we take that piece out and work on it? Loud noises, anticipating it, responding to it differently, because you're conditioned by the trauma experience to have this response immediately, overwhelmingly. Then the generalized anxiety is a different issue that we want to approach differently. Am I understanding what you're saying?
Yeah, absolutely.
All right.
And so then when we think about individuals who have experienced childhood traumas, right? So for a person who has been abused by a family member, sometimes it's hearing the creaking of the floorboards outside
there's some research that shows that that's imprinted on these children if it happens at an early enough age. And so their response to that almost is hardwired in their brain.
Yeah, well, it is hardwired.
Okay. And I think you were asking the question, how do I use this to guide my practice?
Yeah.
And maybe one way that I'm seeing as an opportunity here is to think of the brain as taking the path of least resistance with different experiences. So in the instance of PTSD, right, we're saying that we no longer have to involve the prefrontal medial cortex, right? We no longer have to involve this expensive part of the brain to deal with the same reaction as a brain that we would around certain events. So car backfiring is gunshot. Floor creaking is fear in a child, right? For whatever abusive reason. Maybe as a clinician, understanding that that is the current path of least resistance says exactly what you're saying already. We need to take that out, look at that as a part, and find other paths that work better, because that's no longer serving us, right?
That makes
it's no
sense.
longer the path of least resistance. This is actually more resistant.
And I think that really fits in very well with your idea of emotional economics. So is this old behavior
too expensive?
Yeah, and would you like to try and investigate other avenues
that
helps
would be
a lot?
Less expensive? I mean, I have to have a way to frame it. I have to have a way to hear it. And when I read these articles, that isn't what happens to me. So I need a better modulator. No, not analogy so much as I need a better understanding of how this is applicable, as you were suggesting.
I think one of the places that, and I am by no means an expert, right? But one of the things that I see keep popping up is Bessel van der Kolk's work on The Body Keeps the Score. He's a medical doctor that's gone into this foray of psychology. Really, one of the
trauma. I mean, trauma-informed therapy is his whole deal.
Exactly, one of the foundational creators and understanders of PTSD as a condition. And I really did like that book. I think that book does help frame an idea of why is some of the biology important, or like how can it drive my practice.
So I have met and talked with and read a book by Dr. Mark Gordon, who's a neurophysiologist. And he does a lot of work on traumatic brain injury for the military. And much of that work is focused on...
What was his name?
Mark Gordon. And much of his work is focused on the biochemical aspects of the brain and where the brain injury occurs and how the system adapts and responds and what needs to be rebalanced biochemically so that you can then do other things. It's a whole area that I don't know enough about to talk about or do work with, but I think it's in line with what we're discussing.
I think it comes back to some of the philosophies that I have around psychiatry, right? Psychiatry is a medically assisted therapy overall, right? It's drug assisted therapy, but overall the point is still the therapy.
Right, I would hope.
And we know that a lot of the time antidepressants or anti-anxiety or even things like antipsychotics aren't as effective as they could be. They have a 5% difference in the overall efficacy without therapy included. Mm-hmm. So I look at understanding the biology as just another tool to help assist this idea of getting somebody back to a place of security and getting somebody back to a place of being in control of what they want.
Exactly.
Okay, so let's take our break, and when we come back, I'm going to ask you a question, Brett.
All right. One of the reasons that I want to participate in this show is because it gives me an opportunity to clinically review my understanding of what therapy is and how it works, especially for the consumer. Mm-hmm. So my hope is that we will find conversations that broaden my understanding of that.
And my hope is that we do that in a way that is useful but also entertaining for people, so that they want to listen, not only because they're getting good psychology information, but because they just enjoy the show.
Easy listening with an informational twist. So
That's a new tagline.
They're not sitting there going, huh?
Easy listening with an informational twist.
I'm really good at it. I'm a professional.
You're a professional. If it's Friday, it's Psych with Mike. Okay, we're back. And so does the idea or the language of the emotional economics, does that make that what
yeah,
we're
that all
about?
makes more sense to me. That's a language I can hear.
Yeah.
I get bogged down in the analysis of the prefrontal cortex and the amygdala and all that. That to me is not a language I'm comfortable with.
Mm-hmm. And you make a great point, though, that therapists who are doing therapy, to the extent that they're not comfortable with that, then they're not going to hear that message. All I'm talking about is the first thing you got to do when you're dealing with an anxiety is to identify whether or not it's a generalized anxiety or fear-based anxiety, and then...
And the most obvious way for you to know that is what?
Well, for me, what I would say is whether or not you think that the anxiety is based on cognitive dissonance. So is it?
What I'm hearing is if it's a global reflexive response, boom.
Yes, then that's
I'm on the floor.
PTSD.
Yeah.
Yeah. Yeah. And so when I'm talking about cognitive dissonance, do you see the anxiety as based on two conflicting thoughts that the individual is trying to harbor?
Give me an example.
So I want to ask a girl out, but I'm afraid to ask her out.
Okay.
So that's not, that's not an
generalized
immediate
anxiety. Okay.
Yeah, that's a generalized anxiety. And then, I hear the floor creak and I'm terrified.
So that's like Albert Ellis with rational emotive therapy. The experiment that he offered, he had a guy that claimed I could never have sex with a woman. Mm-hmm. And he said, I want you to go and stand on the street corner and ask the first 100 women that walk by, can you have sex with me? And you'll get slapped, you'll get rejected, the police may be called, but 4 out of 100 it'll say, sure, let's go. And you're not going to know whether it's real or not unless you do it. Mm-hmm. So he would give people assignments like that.
Which you couldn't do today, but...
Well, you can, but you have to really...
Well, yeah. You have to deal with the consequences.
Clarify the anticipatory set.
Right,
yeah.
Right. So, in my view, then, if you've identified that you are dealing primarily with a post-traumatic stress disorder, then the first thing that you have to do is to try and find some way into that. Because what you have to recognize is that a lot of the techniques that we use in therapy are directed at talking to the person's cortex. You got to have rational thought.
So CBT is an approach that's often recommended.
For post-traumatic stress may not be as effective because that's not really
talking to the right part of the brain.
Yeah, you're not talking about exactly.
So then we get things like EMDR. Right? Here's where we start to move into let's get out of the head and start feeling the feelings. We were having a good conversation about this earlier.
Yeah.
If you don't feel those feelings and you don't understand those feelings and find a way to redirect that energy, then...
But I also think that Brett's idea of emotional economics, when he talks about that, what I hear, and I don't know if this is what you intend, but what I hear is that that's affective, AFFECT, emotion-based therapy. That's not cognitive behavioral therapy when you're talking about emotional economics. That is the way to approach the post-traumatic stress disorder when we're talking about it's an activation of those baser areas of the brain. You're not going to approach that by talking to somebody's cortex. You're going to approach that by talking to their limbic system, to their emotions.
So we're back to what does the therapist need to know in order to do what they're doing, and how much of that is even relevant for the client to know. So if I'm talking to you about emotional economics, I'm not going to have this more extended conversation.
Exactly. You don't have to. Now, I would.
I know you would.
You know.
But for me, that's a waste of time.
I know.
Okay.
And
well, I think part of that conversation is valuable, right? In behavioral economics and emotional economics, we talk about the idea that people have biases. And those biases aren't necessarily rational, right? And maybe we steer away from the word rational.
But it's also a message of power. There's an empowerment if I say to you, okay, you could choose to behave differently if you wanted to, and if you could afford it. You know, I could choose to drive a Corvette, but do I want to? Can I afford it?
What would
maybe
I have to sacrifice?
Can I afford it? Yeah, what am I willing to give to have one? So that allows you a way in that isn't a direct challenge that they can rebut or refuse to hear. Because you come up with an example, or they come up with an example of some behavioral choice driven by cost.
And, you know, so for me, it doesn't bother me whether the therapist talks about the biology or talks about emotional economics, as long as they understand that when I am looking at this presentation, trying to do regular CBT is probably not going to be as effective, because that's not the area of the brain that this person is operating out of. Right. And I think that the ubiquity of CBT, and now we're talking more and more about trauma, and I think that there's going to be less effectiveness of that, of those treatment outcomes, because that's not the area of the brain that that person's operating in.
Yeah, that makes sense.
And ultimately, the goal is to move someone from that external locus of control to that internal locus of control. Yeah, with CBT, emotional economics, they're both saying the same thing, right? Of, I'm putting the power back in your hands to make a choice of this thing. Which
is one of the goals we had when we were talking about increasing your level of your sense of security. If you have the power and the autonomy to make the choices, if you're free to choose, you can freely choose to behave differently.
And I think that that's the goal. So the internal locus of control as opposed to the external locus of control is the goal, but that's a rational concept. So initially that person may not be thinking in that area of the brain, and so you that may be the goal for the therapist, right? But that isn't the way you go into the therapy. So the way you go into the therapy is through that affective, AFFECT, the emotional economic way, however that makes sense to you as a therapist, but you have to apply some kind of affective therapy.
So not PTSD per se, but I had an adolescent male client that was on the autism spectrum, and he was really in trouble a lot because he would decompensate and act out because kids bullied him and picked on him and what have you. And I had to work with the school, the teacher, the family, and the student to say, is there a way we can get a handle on this and achieve different outcomes? And it wasn't useful at all to understand or explain where, why, how is he autistic? What makes that happen? It was more useful, we found, that to say, can we find a way to characterize this for him where he can feel a sense of power and where he can choose from that power to make different choices. And so I was able to ask him, I said, do you want to be popular? Do you want to be liked? And he was like, yeah. I said, do you have any idea why people don't like you? No. I said, well, you're a snot sucker. You make these horrible noises all the time, and people react negatively to it, and you don't even see it. You don't even notice it. You just do what you do. And I had to work with the teacher on like a red card or a yellow card whenever he would suck snot, so he could hold it up, and he would consciously learn to recognize after the fact, oh, I did that. And then we worked on could you do something instead, like blowing your nose? Is this just a reflexive, habituated behavior, or is there some, we need to go to an ENT and find something to deal with this, which isn't going to change the autism spectrum, but it can change your acceptability level and your intensity level to maybe a better place.
Sure. And what I would say is that is an example of behavior modification, right? Which is a different kind of therapy that we haven't talked about, but or at least in this show. But the initial way you went in was through emotional economics.
Yeah.
So you didn't start with the behavior modification. You started with the presentation of the emotional
economics. It doesn't help
economics.
say life sucks and you're screwed.
Right.
It helps to say we can do something with this if you'll work with me and if your system will tolerate it.
Yeah. And it goes back to what Michael was talking about when you were moving him from an external locus of control to an internal locus of control.
Yeah.
And all of those things those are the goals of therapy. But if you are talking to a part of the brain that isn't being triggered, it's going to be less effective. I'm not saying that no one ever got help for post-traumatic stress through cognitive behavior therapy, but I'm saying that if you think about what the biology is, my sense, my understanding of human pathology tells me to be informed by what I think is the biology, and then use that to help me to devise a treatment plan that I think is going to be most effective.
Efficient, effective, economical.
Sure.
Yeah.
Then I think further about other types of therapy modality, like drug-assisted therapy. So if we look at things like psilocybin-assisted therapy or ketamine-assisted therapy, these are really getting a lot of attention right now in the PTSD community, and understanding that neurobiology and the neurobiological effects of the different drugs. What are those pharmacodynamics of those different drugs? We can build a better toolkit.
Are you asking, or is that rhetorical?
It's rhetorical.
Okay.
Because he'll go into 30 minutes. So.
No, I took your addiction and treatment class.
Yeah.
Yes.
And I'm not saying that isn't going to be a breakthrough. I think that, especially for me, when you're talking about the medically assisted treatments for anxiety or for post-traumatic stress, I think psilocybin is a more effective molecule than the ketamine.
I agree.
But there are real reasons why that happens, and they're based in biology. I mean, the way in which that the psilocybin molecule opens up the connectedness of the brain can allow you to have a conversation with that person in a different way that isn't necessarily triggering for them, and they can get realizations out of that experience that they might not get any other way. And so I think that can be very effective.
So is the reverse true for depression, with ketamine being the predominant or preferred?
Ketamine is the preferred for depression, yes. Yeah. And I don't know. I don't know. My sense is that the reason that ketamine was the initial breakthrough drug was because it was the one that they were able to aerosolize and be able to deliver in the context of the doctor's visit. And the ketamine is a 15-minute reaction rather than a 6-hour reaction. So, I mean, if you're going to do these psychedelic drug-assisted molecule therapies, you're talking, that's an all-day
treatment. You have to stay there for 90 minutes afterwards, though, don't you?
For the ketamine, yeah. It's just to make sure that there are no adverse reactions, but you don't have to stay there for 6 hours.
Yeah.
If you took psilocybin, you'd be there for
all day.
Yeah.
Well, and just to reiterate that this is another tool in the toolbox, right? I see a lot of Instagram ads or Snapchat ads for this idea of ketamine-assisted therapy on people saying, "Oh, I feel so much better. I feel so much better." And there's a real danger in that advertisement, I think. It's important to understand that this is another tool in a large toolbox, and isn't the only thing to reach for, and might be one of the last things you start to reach for. Yeah. Other work has to occur first.
That's right.
I see the same conflation with EMDR, right? People look at the exercise of tapping, and they look at different, the light bar exercise things, and that is just so far down the line in EMDR and so far removed from the actual work that's taking place, the emotional lifting that's taking place.
And especially with what you were saying with the ads, but to me that's just like any pharmaceutical agent. It's not the patient's job to decide what medication is best for them.
Yes.
And it really burns my behind that you have ads on television for any pharmaceutical.
Talk to any physician in America. They say the same thing about any drug, that somebody comes in because they've watched all these ads
That's
on
right.
TV. Oh, I want this drug.
And that is exclusive to the United States.
Yeah.
Other countries don't
Not
do
allowed to do
this.
it. Yeah.
Well, because it doesn't make any logical sense.
No, it's economic.
Yeah, I mean, even
For a
if
controlled market.
even if you are a doctor, you're not supposed to devise your own treatment plan. And if you're not a doctor, you don't really have the informed ability to decide that this medication is a right fit for you. So, but that point is well taken. Just because even if you anecdotally know somebody who had psilocybin treatment and that person said, oh, it was great for me, it may have been great for them. That doesn't mean it's a great choice for you. But if it is something that you are interested in, it is a growing
That's
field.
what happens all the time.
Yes.
I mean, think back about your years of doing therapy with adolescents on ADHD medicines.
Right.
And their family members would say, oh, Joey takes this pill. Why don't you give it to Bobby? It'll make him better.
Yeah.
And not involve any kind of professional, medical, or psychological in that loop.
Well, and this is apropos of nothing, but what really burned my behind is that
I've always wanted to know.
this would always happen, or most commonly would happen, at the end of high school when the person was getting ready to take the ACT or the SAT.
Yeah.
And then they'd say,
Yes.
oh, well, this medication,
Here, take it on this,
wait a
yeah.
minute. No, if you're just going to use this as a performance-enhancing drug, that's not the point of the medication.
Yeah.
But a lot of people used it for that.
Tisk, tisk, tisk.
So how did this strike you? Was the conversation okay?
Yeah, because we got away from an intense analysis of the chemicals in the amygdala, and we talked about how that knowledge is useful to a therapist and to a person in therapy.
Good. So hopefully,
Like a good article, right? We've taken something from it
The
and
substance.
applied it to ourselves.
Exactly.
that's always a good thing. So hopefully that was helpful for other people in the audience. As always, if you have any questions or comments, you can get us at psychwithmike.com. We would love it if you would go to Apple Podcasts and find Psych with Mike and leave us a comment and a review. But most importantly, the thing that is most helpful for us is for you to go to the internets and find us on the YouTubes, Psych with Mike there, and subscribe to the show. That really helps other people to be able to find the show. And as always, the music that is in Psych with Mike is written and performed by Mr. Benjamin DeClue. And as always, if it's Psych with Mike, now I can't even talk.
If it's Friday.
If it's Friday,
It's Psych with
Psych with
And
Mike.
like the other way. If it's Psych with Mike, it's certainly Friday.
Absolutely.
We'll edit that.
I think you should leave it in.
Start having these shows.
But what I do want you